The present case report discusses the treatment of a patient with neurofibromatosis who had undergone unicompartmental knee arthroplasty for severe arthritis and pseudarthrosis.
Neurofibromatosis is a genetic condition that causes tumors to develop on the nervous system. Type 1 NF is caused by the mutation of gene located on chromosome 17 that results in the loss of a protein called neurofibromin that helps regulate cell growth. Uncontrolled cell growth due to type 1 NF has many manifestations, including bone deficiencies such as congenital pseudarthrosis, limb shortening, and scoliosis. There are no reports of NF and knee arthroplasty or NF and ORF are present to date.
We describe the case of a 76-year-old Asian female patient who presented with severe pain and a valgus deformity of the right knee. Her past medical history included neurofibromatosis, which resulted in a severe anterior slope of the right knee, limb shortening, and congenital pseudarthrosis. She was diagnosed with severe anterolateral osteoarthritis and eburnation of the right knee that was treated surgically with a lateral unicompartmental knee arthroplasty. Bone and cartilage fragments were removed from the joint space, and a UKA implant was inserted. Perioperative imaging revealed that the procedure resulted in the correction of the valgus deformity. Pain was reduced, and the patient was able to walk for 10 meters without support during the immediate post-operative period.
1 week after the surgery, the patient sustained an oblique tibial fracture that extended from the medial edge of the implant to the medial slope of proximal tibia. This complication may have been due to the large size of the implant or potential sagittal overcutting. The fracture was treated surgically with a rotated anterolateral locking plate inserted into the distal tibia.
The patient was capable of ambulation at full weight load at 2 months after the fixation procedure. It is critical to recognize that there are no standard protocols that can be used to guide the treatment of neurofibromatosis-induced osteoarthritis. The specific preoperative condition of the individual patient plays a large role in determining the appropriate treatment option. The bone deformities observed in patients with neurofibromatosis requires customized therapies tailored to each condition. In this case, the availability of custom-fitted UKA implants might have prevented the complications that developed after the UKA procedure. Our findings underscored the fact that the orthopedic manifestations of NF pose a significant challenge for orthopedic surgeons. In this case, the complexities associated with the multiple complications of NF necessitated careful planning and specific precautions. Various patient-specific treatment options should be designed and evaluated prior to surgery in order to assure successful outcomes.